Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, Associate Dean of Native American Health and Director of the Center for American Indian and Minority Health at the University of Minnesota Medical School. I'm also a family physician for the Fond du Lac Band of Lake Superior, Chippewa. And I'm your host today for our program tonight on stroke and other neurologic problems. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@wdsc.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Vikram Jadhav, a neurologist with Essentia Health, and Dr. Dylan Wyatt, an emergency medicine physician with St. Luke's Hospital. Our medical students answering the phones tonight are Katie Benson from Staples, Minnesota, Claire Buntrock of Rochester, Minnesota, and Abby Rader from Glencoe, Minnesota. And now on to tonight's program on stroke and other neurologic problems. Thank you both for being here.
Thanks for having us.
Thanks for having us here.
So let's just get started with the question that's always at the top of these shows these days is how has COVID affected your work? Well, around neurology in this instance. Have you seen more strokes because of COVID? Seen less? Go ahead,
Yeah,
Dr.
definitely. I mean, we have seen an uptick in the number of strokes which can be exclusively attributed to COVID because now with sufficient research that has gone into COVID, it is known that whenever somebody has COVID infection, the blood can thicken up a little bit, and this can predispose the patients or the individual to having strokes because of the thickened blood, which can form clots. So we are seeing sometimes patients as young as even 30 or 40-year-old who are having strokes because they have COVID infection. Of course, it was much more initially, but now as more and more people have gotten their vaccines and are immunized against the infection, then we are seeing less and less numbers. But definitely COVID is an independent risk factor for increased strokes, not only in older people, but younger patients also.
And what is the time lapse between having COVID, or is there a given time lapse, or is it variable on between when people get COVID and when they might have the stroke or
it could be variable, but usually the risk is front loaded. So in the initial stages, in the acute phase of the infection, you can definitely have a higher risk of stroke, and that can keep on waning off as you are more and more away from as you improve and recover from the infection.
Okay. Dr. Wyatt, anything to add on that one?
From our perspective, in kind of trying to identify strokes in the emergency room, it sort of lowers our threshold with which we'd consider strokes in a patient and kind of broadens the way we think about it in even younger patients. Whereas before, we may have had a higher thought for something more like a complex migraine to mimic a stroke or something else. Now we'd have a lot higher on our thought process. You know, did this person have COVID? Maybe that means that they're having a stroke despite them being younger than what we would traditionally think being a risky age.
So as doctors, we call that having a differential, all the different things we think about when a patient comes in. And you're saying COVID has really broadened our differential to include something we wouldn't include before. So
Definitely. For every patient we suspect of having a stroke or we get called for, we do order a COVID test for them.
Okay. Let's go back to some basics. Dr. Wyatt, tell me what the difference is between a TIA. For instance, what is a TIA, first of all, between a TIA and a stroke, and how are they treated differently?
So a TIA is a transient ischemic attack, and it's basically just fancy medical terminology for a short period where blood flow is not reaching a part of the brain. In essence, that's what a stroke is. It's blood flow not reaching a portion of the brain. The effects we see on the body, the things that are classically sort of brought throughout to everybody to know, the facial drooping, the weakness, that is from a lack of blood flow to a part of the brain. When that stops spontaneously after a period of time, it's a transient change, and therefore is a transient ischemic attack. It differs from a stroke, whereas a stroke is a bit longer lasting. Now, there is some blurring there because occasionally there can be spontaneous improvement in strokes, and it's not exactly a black or white, but generally speaking, the stroke is a longer persistent symptom, whereas a transient ischemic attack self-resolves.
When do you call Dr. Jadhav? When do you call the neurologist when you're seeing people in the emergency department for this?
For me, a lot of it depends on, number one, the complexity of the case. Sometimes it's a slam dunk sort of, the symptom started at this time. It is entirely in a distribution of the body that is consistent with part of the brain and therefore highly suggestive. We do a CT imaging study which would potentially show the area of concern. Then oftentimes we talk to a neurologist potentially on one hand to help us, if it's not showing what we would have expected in regards to the CT, kind of broaden the way that we're thinking and just say, hey, kind of lend me your ear here, let's put our brains together. The other thing would be, hey, we've identified this problem. Do we need to do a clot busting medication to try and get rid of that clot, or is it big enough and close enough that we can have someone do what's called neurointervention, which is sort of like when people put stents in the heart to get the clots out there. And I think you'd have a lot better explanation about that process.
Yeah, I agree. I mean, we work closely with our ER colleagues because we always consider our ER colleagues as like the first line of defense, and they are the first ones to tackle patients who are coming in with stroke-like symptoms. And as Dr. Wyatt rightly mentioned, you get the CT imaging, which is a quick imaging to make sure whether this is a bleeding kind of a stroke or an ischemic kind of a stroke. An ischemic kind of a stroke is one where you actually have a clot blocking a blood vessel, which is preventing blood flowing into a particular part of the brain and not getting enough oxygen. So if the patient has blockage in an important blood vessel, which is affecting that particular part of the brain, we can actually put a catheter through the groin or the arm and go all the way through the blood vessels into the neck and that part of the blood vessel which is occluded, put in a stent retriever, which is just like a stent but attached to a wire, capture the clot and pull it out. And that way we restore the blood flow to that part of the brain and preserve the brain function. So this is called an emergent thrombectomy. And all of this is very fast because anybody who comes in into the ER suspicious for a TI or even a stroke symptoms, the brain attack or a stroke code or a stroke alert, these are the codes that get activated. And it's almost like a chain reaction that the patient gets rushed into the CT scanner, the neurologist gets called, and this even happens even in the small ERs where you do not have a neurologist on call, and you can set up a video monitoring, so we can sit remotely in Duluth and can evaluate patients all over Northland.
So you're saying that I've worked in some clinics up by Bemidji. If I'm up there, and as long as they have that monitor system,
Yes.
and it could be a basic screen even.
It could be just a basic screen with
Yeah.
Zoom or some kind of a software.
Doctor, this is what I'm seeing on my patient. Can you take a look as well and make sure that you agree with this plan, and then where do we
Yep.
go from here?
Yes,
Okay.
agree. And
So-
then if the patient is a candidate for getting the clot buster, like the IV thrombolytic medications, they get that, and then they are shipped over to the main center where the team is already ready for the patients. Like they are shipped to the angio suite, which is like the cath lab equivalent for the brain, and then we go in and do our catheter business over there.
So Dr. Wyatt, anytime a student, or a patient presents to you right in the emergency department, the time starts from the minute they walk through the door, and there's a protocol that you're following, it sounds like.
Absolutely. It's very protocolized for a good reason. Time is brain is the phrase we love to use with strokes because it's true. Every moment that part of the brain is not receiving blood flow, damage is being done, damage that can be permanent. So we are very regimented in the way we go about doing that because there's not any time to sort of faff about worrying about, oh, wait, we have to do this or maybe this. No, it needs to be protocolized and very simple in a way. You want to remove some of the thinking about the process and allow the thinking to be about the presentation and the patient.
And it's interesting because this whole protocol has come about because doctors and nurses and the whole health team have worked together to find the barriers to getting people treatment. So it's a nice result of that collaboration between providers.
Absolutely, I think so.
Yep.
Dr. Wyatt, what should you do if you suspect someone's having a stroke?
If you suspect you or a loved one is having the stroke, the most important thing to do is to call 911 right away. Again, time is brain, and if you are unable to communicate, trying to get in touch with someone who can help you, who might know some key pieces of information that we need to know. When's the last time you were completely at your normal? You know, when is there anything like new medications that may not be on our list of medications that could prevent us from doing certain treatments? But the most important thing is calling 911 to be brought into the emergency room, because the alternative is giving more time for injury to occur within the brain.
Anything else to add, Dr. Shah?
I agree totally. I mean, time is brain, and recognition of symptoms is very important. See, in the common world, like we know, heart attacks, there is very good recognition. Chest pain, people are always worried, am I having a heart attack? But the same thing is not true for a stroke, because sometimes you have weakness or some numbness on the arm and people think, you know what, I just slept on the wrong side and this will go away. Let me just shrug it off, shake it off. I have had carpal tunnel, something like that. So that importance of recognition of the symptoms and coming in is very important. So there is a very good abbreviation or like a mnemonic that can be used. It's called Be Fast. So the B stands for balance. So if somebody is having lack of balance and cannot walk in a straight line, unsteady, almost like you're drunk but without having a drink. And E in that B fast stands for eyes. So if you're having loss of vision or you cannot see from one side of the field cut. F is for facial droop. So if you're having facial droop, drooling of saliva from one side. A is for arm and leg. So if you're having arm and leg weakness on one side. S is for slurred speech. So if you're having slurred speech. And T is for time. So if you have any of these above symptoms, time is of essence, call 911 and come to the nearest ER.
Okay, excellent, thank you. Sometimes though we don't get our patients in, they might be fearful of the hospital system for whatever reason.
Yes.
So say someone had a stroke, they think they might have had a stroke, or they think their loved one might have had a stroke a month ago and never went in. Or is there anything that can still be done?
Of course. More importantly, there are two phases, like the acute phase of the stroke wherein you're trying to contain the size of the stroke and limit the kind of damage that can be done. But if that phase is already done and over with, and if the stroke is over couple of weeks old, you can still address the factors that caused the stroke in the very first place, so as to prevent future strokes. That's called secondary prevention of strokes, and we can still address that. So for those things like looking at the heart, looking at the blood levels of common things like, does the patient have diabetes, does the patient have uncontrolled high blood pressure, does the patient have a bad lipid like high cholesterol. We address all those factors, and this can be done in the clinic as well.
Okay, and how long does it take if a person has had a stroke before they start to typically correct for the things that have happened? For instance, speech comes back, or motor, their movement of their limbs comes back. Is there a given time?
There is no like time set in black and white, because each person is different, and it depends on how healthy you were or what are the other comorbidities you have, as well as your age. Now granted, if you're a younger person who had a stroke, you're going to bounce back much faster and better as opposed to somebody who is much older. But the most important thing to remember is have very aggressive therapies right at the beginning, because if your initial curve of improvement is pretty nice and steep, then your final outcome is going to be good. So you can start expecting some improvement in your stroke deficits over weeks, if not months. But if you haven't had any improvements after a few months, then the likelihood of having a very good outcome is going to be much lower. Okay. So it's always good to be aggressive about therapies, very front loaded, like right at the beginning. And we tell our stroke patients, don't get frustrated. This is expected. Just plug on through this and you will see the changes day by day, like baby step improvements.
You talked about what would happen if someone had an ischemic stroke or a blockage, but what happens if they have a hemorrhagic stroke? What's the treatment then?
That's a very good question. There are the hemorrhagic strokes, they do not tend to be as common as the ischemic strokes. And there are a couple of different types of hemorrhagic strokes. In one of the hemorrhagic strokes, like you have the blood vessel which has just burst or ruptured, and that is bleeding within the brain substance itself. And then the other type is like called subarachnoid hemorrhage, which is rupture of the blood vessel because of an aneurysm. An aneurysm is an outpouching or an abnormal growth in the blood vessel, and the vessel just keeps on ballooning up, and it'll keep on growing till it cannot grow anymore, and then it'll rupture. This type of bleeding is between the layers of the brain. Both of these bleeds, different types of bleeds, are bad. They can kill you, and the treatment has to be different. For if the bleed is large enough that it is compressing part of your brain, then a neurosurgeon may have to open up your skull, take out the blood, and relieve the pressure. The same thing for subarachnoid hemorrhage as well, like the bleeding between the layers of the brain. But to treat those kind of strokes, we have to treat the aneurysm which caused the bleed in the first place. So the way to treat the aneurysms, previously, like say 20-25 years ago, a lot of these aneurysms, you had to open up the skull and you had to clip the aneurysm from outside. But now with new inventions and catheter-based procedures, we can have the same approach wherein we put the catheter through the arm or through the groin, go all the way up to the part of the blood vessel which had that abnormal outpouching and the aneurysm growth, and put coils in there and seal up the aneurysm to prevent the bleeding.
Around the coils?
Yep, coils, and then just pack up the aneurysm. So there is no more blood that can go through the aneurysmal growth. And now with new invention, there are we are even stepping beyond coils. There are different kinds of stents and web devices which are individually shaped to the aneurysm itself. So things are just improving. Like every 6 months there is a new device that comes up that helps us to treat and improve patient outcomes.
Some of those also sound time dependent. So do you get, Dr. Wyatt, do you ever get calls from our rural communities on some of these neurological issues first? Are you first line there too?
We often do, yes. And it's an honor to be able to be a part of that care to help out because everyone has different capabilities in their institutions, and it's just the nature of the institutions themselves. And oftentimes we can help direct certain parts of the therapies that can lessen the chances of things getting worse. For instance, if someone has one of these bleeds, very tightly controlling the blood pressure, walking folks out there who may not be as closely familiar with that tight blood pressure control, aggressive blood pressure control, on how to do that. Hey, do this while you're carefully transporting them and trying to facilitate getting them to one of our facilities to get them sort of definitively taken care of. It's an interesting part of the process. And also just to kind of jump off of what you were saying too, it can also be very challenging. We oftentimes get calls where there's a differentiation between is this bleeding or is this a lack of blood flow, the ischemic type, and that can be, unless you are looking at the images, it can be very challenging to do. So for everyone at home, the identification is those neurologic changes, that be fast signs, not worrying about one way or the other which one it is, just getting them into us, and we'll take care of the rest of that stuff.
Excellent, thank you. Dr. Jadhav, have you ever heard of this, a stroke shower on an MRI?
So what essentially it is, like there are multiple foci of strokes all over the MRI and all parts of the brain. So that can happen if the stroke is coming from a clot from the heart, or from a proximal source instead of just one blood vessel. Because if it's coming from a more central source, then that clot might have fragmented and gone into multiple blood vessels. So that way it is showing up in different parts of the brain.
And it might not show up on a CT scan.
It may not show up on a CT scan. A CT scan is an equivalent of, like, let's say a black and white picture compared to an MRI, which has more definition and different kinds of slices that exclusively look at different kinds of pathologies, like what is this, a tumor, is this a stroke, is this a bleed, or is this like a demyelinating lesion. So that's the information we get from the MRI, whereas a CT scan would be helpful just to rule out, is this a bleed or is this something else going on.
Right, it's one of the first lines on that protocol.
Yes.
And then depending on what that answer is, then you go down another line on the protocol.
Yes,
that's the point.
and very small strokes may not be able to be picked up on the CT scan.
Okay, good discussion. Can a trauma such as twisting or cracking of the neck cause a stroke, Dr. Wyatt?
Yes, it can. Especially, there have been, to my knowledge, a slight increase in instances of those recently. And oftentimes it's whether it is from a sports-related injury or a treatment-related injury, and where someone is attempting to crack someone's neck, you can actually have tearing of the artery, or if someone is older, dislodging of some of the vascular disease, some of the hardening of the arteries that happens with age that can then, as an embolus, go up to the brain and stop blood flow. So absolutely, yes, it can.
Dr. Jadhav, I saw you nodding your head. Do you have more to add to this?
Yes, definitely. Like any kind of manipulation which is a bit more excessive and which should not be done, like hyperextension of the neck. This is similar to what you might have in a whiplash injury if you're having a motor vehicle accident. So it's the same kind of mechanism in which you can have tearing of the blood vessels, which is called dissection, which can cause a clot to form over there and then cause a stroke. So we always tell our patients, as we get older, do not indulge in any kind of activities which can cause sudden exaggerated movement of your neck. The neck is meant to support the head, and that's about it.
Right, so as you're aging, be careful of those upside down yoga moves, putting that stress on that head.
Yes.
Yeah.
We're not saying to stop playing hockey. Maybe just slow down a little bit. You know,
Yeah,
you don't
yeah.
Just be smart
you don't have to
about
play
it.
like
Yeah.
you're 30 anymore.
Yeah,
Yes.
be aware,
Right.
right, that you're aging and you're human, right? Do individuals who are immunocompromised have a greater risk of strokes?
Yes, they would be having a greater risk of stroke for sure.
Why is that? What's the mechanism, as we like to say?
Well, I mean, basically it's your ability to fight against any kind of pathology. And sometimes if you are having affliction of the blood vessels, it's ultimately stroke can happen because lack of blood flow to the brain. So if your vessels are getting affected for any reason, then that's going to result in less blood flow to that part of the brain, and you're going to have a stroke from.
And a lot of people who are immunocompromised have inflammation, and we know that any inflammation of the vessels puts you at higher risk for heart attacks, strokes.
Definitely.
Right, anything happening there. Good. Can someone have a stroke without knowing it, Dr. Wyatt?
Absolutely, they can. Not knowing it or not realizing that what they're having is a stroke. Oftentimes, a challenge for us in the emergency department is when we have people who wake up in the morning, having gone to bed at 8, 9, 10 p.m., wake up at 6, 7 a.m., and suddenly they can't move the left side of their face or their arm. We don't know when that occurred. It could have been 5 minutes before they woke up. It could have been 5 minutes after they went to bed, or any time in between. Furthermore, some strokes are very, very subtle. It's not uncommon when we do imaging of people who are in their 70s and 80s that we'll see these small changes of small vascular changes that could indicate very, very, very small strokes. Not big enough to cause a large clinical manifestation, but small enough that it's present. So absolutely, absolutely it can.
Anything to add, Dr. Shanoff?
Yeah, as Dr. Wyatt said, we have a term for it. We call them silent strokes because they are in a part of the brain that really did not cause so much deficit that was evident for the patient to know, and they just probably shrugged it off. And then once you start probing, are you sure you didn't never had this? Well, yeah, maybe like 5 years ago, my arm went limp for a while, but then recovered so fast that I didn't really bother to see a doctor at all. But then that imprint of the stroke is always left on the imaging, and then we can come to know something happened long time back, but you recovered from it.
If a person has a pacemaker, are there any contraindications to treatments of a stroke?
There should not be, but the only big contraindication that we come across is to getting the MRI to look for where the stroke was and what is the size of the stroke. But having said that, that's not a complete deterrent because clinically we can guess like, okay, where is the stroke and what is the size and what do we need to do. So that should not affect us in treating the patient appropriately, but usually patients who have pacemakers, they may not be able to get an MRI. Now newer pacemakers, they are very MRI compatible as well. You just have to ask the cardiologist, and then the cardiologist would opine, and yeah, sure, we'll just be on a watch by, and then we'll see how things are going, and they can approve and then get the MRIs done.
Okay, thank you. Dr. Wyatt, let's take it back a little bit. What happens if you restrict an artery in the neck?
So that could lead to a variety of different things. In a healthy, very young person, if you restrict a single artery in the neck, it should be fine. There's built-in sort of collateral blood flow, multiple different streets. You know, when 21st Avenue East is closed, there are other streets available to go around. The same thing is true, but as people age, those arteries are not all of them function at 100% capacity. And so if your artery that has 80-90% capacity is the one that's occluded, and the others have 30-40% capacity, suddenly you can demonstrate symptoms out of a stroke out of nowhere. Even though it may seem dramatic, it's just that it has exposed a vulnerability in the other arteries.
Nice explanation. And occluded means blocked.
Yes,
right?
yes,
Thank you.
absolutely.
Yeah.
Okay.
The
Looks like
brain
you
is
wanted to add-
very, very resilient organ, and
Yes.
it'll keep on squenching blood flow from different levels till it cannot get any more. And then usually at that stage, it becomes a crash and burn, because then things start falling apart. Usually we like to explain to patients using this analogy: you're driving from the cities to Duluth, you're taking the freeway. If the freeway is blocked, you can still get to Duluth using the smaller county roads. It's just going to take longer. So the same way, the blood takes longer to get to that part of the brain, and at some point the traffic might stop. And that's when the blood stops to that part of the brain, and you're going to manifest with some stroke symptoms.
That's an excellent analogy. Thank you for that. I think about a lot of patients who feel like I don't know that disease because I'm not feeling any symptoms, and then all of a sudden they're at the danger point because all the implications of the disease have multiplied. So, thanks.
Our brains and bodies are always in good self-survival mode, regardless of what kind of damage we do to our brain, voluntarily or involuntarily.
And that's why people who are older have more tendency to, because culmination of all these things, right?
Yes.
Yes.
Thank you. Let's do an easy one for you. Do any of those brain exercises you see on TV or the internet actually work to
As
ward
in-
off dementia or memory
Well,
problems?
the one thing that has been proven to delay dementia is actually physical exercise.
Okay.
So if you are indulging in physical exercise regularly, then there is good evidence to show that you can delay dementia.
So if you're
But
doing those brain activities while you're exercising, then they
that
could
may help. Like a Sudoku puzzle is not bad to do once in a while.
We're going to see a bunch of people doing Sudoku during Grandma's
Yes.
Marathon next year, aren't we?
Yes.
and have other problems. Then they're going to be visiting you for having fallen down.
Please don't.
Okay, we talked about TIAs, a lot of questions about those. It seems like more and more, this is a general question, seems like more and more people are developing tremors or people develop tremors as they age more commonly. Does that mean anything? Should we always be concerned about a tremor?
Yeah, we should be, because it could be like a warning sign for a disease like Parkinson's,
Okay.
which is well known. So you can have different kinds of tremors. Now, Parkinson tremors, they can be like resting tremors when you're just sitting and your arm can be having, it's called classically like a pill rolling tremor. So that's one of the tremors. You can have tremors which could be just very benign. They may not be associated with any kind of major disease, and those could be just familial. And those could be tremors we call sometimes like action tremors, wherein you're reaching for a cup or some water and then you're having some jerky movements. So there is an entire spectrum. But the most important thing is you should not ignore tremor, because it could be a warning sign of an underlying big disease. If caught within time, you can delay the progression. So you can visit your neurologist and have them evaluate what kind of a tremor is it, and do we need to do any tests about it. Have them evaluate that. Tremor is one of those things that it's always helpful to evaluate it in person rather than just get some imaging and think about it.
Point is, call your doctor.
Call your doctor. Don't be shy about it.
Thank you both. I want to thank our panelists, Dr. Vikram Jadhav and Dr. Dylan Wyatt, and our medical student volunteers, Katie Benson, Claire Bentrock, and Abby Rader. Please join Dr. Ray Christensen next week for a program on upper GI problems, when his panelists will be Dr. Robert Erickson, Dr. Victoria Heron, and Dr. Brad Irwin. Thank you for watching, and good night.